So in terms of the tool, we needed a tool badly. Like, we knew this information was out there, we knew Pathways was rich in data, but people at my level and above didn't have any way of quickly analyzing what's going on. I can't set forth my contract specialists unless they understand where the shortcomings are and who they need to contact and what the benchmark is and what sort of an intervention we could do to improve the situation. So we really needed a dashboard that gave us that information. So we partnered with Strata Health early in 2010 to design from the ground up what the dashboard should look like, what elements within Pathways database we should be focusing on bringing up into the dashboard. Yeah, we talked a little bit about the data elements as well. The other thing that it does is going to, you see that in the dashboard there's other interesting information that really assists me in my decision making. So one of the things that it does, it actually it assists me with the decision point with the purchase of temporary beds. And so at any given time, the hospitals are screaming, they've got 40 people in emerge who have been no bed to go. Our ALC rates are really low. Like, we don't have a lot of people upstairs in the ALC, but they are there. There are times when I need to make a decision point about purchasing a temporary bed from our community groups. And so when I look at Pathways, when I look at ALC rates, when I look at vacancies, that helps me make a decision point as to whether or not I'm going to spend money to buy a temporary bed. So that's been another great tool as well. We're going to have David just talk in a few minutes just about the demonstration of the tool. Just want to talk very briefly about our next steps with this tool, as you'll see. We want to roll out the information so our contractor partners can see the data. So there's no use telling a contractor partner, here's your expectation, if they can't A, see their data quickly and easily, and B, more importantly, how they compare to their peers. Because, you know, at the end of the day, it doesn't matter if I have got a big financial stick and I pick up the phone, I'm nasty and say, what the heck are you guys doing, right? It's not going to work because there isn't enough of me and enough time in the day for me to do that. We think a far greater motivator was actually is to say, how am I comparing against my peers? Because frankly, none of us like to be at the bottom of as an outlier, right? You don't want to be an outlier. If you're not all that motivated, you might be happy in the middle of the pack, but you don't want to be an outlier. So at the end of the day, we're hoping that when we release this information, that they'll see clearly and transparently how they're doing vis-a-vis their peers. The other thing we want to do is set performance targets and expectations for them. So as I said, we're getting close to setting some benchmarks. Depending on the technical aspect of it, our hope would be is to roll out the system to them in January and say, here's the new Strata Health IQ. Here are your targets. And here's the process that Fraser will do in order to review those targets. And here is how we're going to interface with you in the coming months in order to improve your levels. Because we know, looking at the data, that there is a lot of improvement that we need to make. So we found actually the tool to be incredibly powerful. So Dave, we'll turn it over to you.
I just have to switch my laptop over, but as I'm setting up, as Keith mentioned, about a year ago now, at the time when sort of the care delivery model was coming into focus, Strata Health recognized sort of a need for us to have a better way to explore data and pathways. We found that at the operational level, there was really great data. So if I was a case manager, I could easily print my caseload, or I could print off a wait list. We did those things fairly well. What we found we needed more of was sort of strategic level reporting, and that's where we had an opportunity to partner with Keith to look to him as sort of a clinical person to tell us what do we need to do, how do we need to build a dashboard, and what's it going to look like.
I'd also like to point out that the data you're about to see is real data. We've anonymized some of our contractor partners, so we feel it was appropriate for you to see their data. But the rest of the data that you see is real.
Yeah, so Keith was kind enough to let us use a sort of a real snapshot into the data. So this is Strata IQ, and we're focusing on the residential side for the Fraser Health Authority. So it is going to be kind of focused on the bed matching side of the Strata Pathways suite. So we've broken down the data into some of the key indicators that Keith mentioned. So we've got, I'm not sure if you can read at the back, so I'll be pretty clear here. Information around decline. Keith mentioned that's one of the key things they wanted to kind of weed out of the culture. So a big focus of the dashboard is going to be, why are people declining? How often do people decline? That sort of thing. Then we get into occupancy rate and vacancy volume, so how full are the facilities. Vacancy turnaround, certainly a big part as well. And then down at the bottom here, we've got average wait time. How long are people waiting to get into residential care, whether they're from their home in the community or an acute care setting?
We saw this screen as being very useful for members of our senior team, so they didn't have to drill down to look at sites, but they could get a pretty quick idea of what was happening in Fraser. So just looking at those clocks at the bottom left, you can see our wait times from community to residential care is 86 days, from time of assessment, from time of placement, and from our acute site is 28 days, from acute to residential.
Can you just walk us through what this is telling us? So what does the orange bar graph generally tell us?
Sure. Yeah, we'll get into more detail as well as we go through the various screens. This is what we term the senior executive dashboard for someone like Keith to log in very quickly to see what the numbers look like on any given day. So, as an example, this chart right here, the vacancy turnaround time it's called. This is how long it's taking providers to fill their bed in days. And really at this level, we're sort of at a 30,000 foot view where we're looking at the health authority overall. One of the key components of Strata IQ is the drillability as well, and we'll see as we work through how you can really zoom in and get a much greater level of detail down to the individual facility level. So right here as an example, we're looking at kind of aggregate data. We've got vacancy turnaround time for all the facilities in Burnaby, New West, Coquitlam, and on down, but it's all of the facilities combined into one overall number. So when we get through to the later screen, you'll see drill down to the individual service provider level.
So if we're looking at those two numbers on the top left right now, decline rate is 31.48, occupancy rate is 98.86.
Okay.
Is that a good decline rate?
That's, in my estimation, not good at all. It's too high. Probably the vast majority, the number's a bit misleading in that when bed is matched with somebody, and if the community access coordinator does an intervention and says, yeah, I don't think that's a good match for that person because I know that building they can't do the clinical outcomes, then the access coordinator actually then declines it and they can move on. So there's a high chunk of declines that are done actually by access staff, but the system actually breaks down the reasons for decline. So actually we can extract the reasons for decline so we can focus in on the declines. And the one I'm mostly interested in is when a site says they haven't got the proper staff or room mix in order to serve the client. That's the one I'm interested in. Not interested in the one if the family turns it down or there's a community intervention. It's more about why the site's turning them down.
So yeah, there's a lot to that 31%, and then as we get into the drill down, you can see what makes up that, what percentage are staffing concerns, what percentage are clients refusing, that sort of thing. So I'm going to move on through the individual indicators so we can see a lot more detail. The first one I'm going to click on is in terms of the wait times. So again, I apologize if this is kind of small, I'll walk through it. So what we've got here is how long it's taking clients to get placed into residential care, and I'm coming at it from a community perspective. Clients waiting in their home, how long it's taking them to get in. So we've got all the various sub-regions of Fraser Health Authority and just a little bar chart in terms of how long they're taking to get placed. And coming at it from the other side, we can look at this from an acute care perspective. So just with a click here, I can now have a list of all of the hospitals within Fraser Health, how long patients are waiting in the hospital and to get placed into res care as well.
So it's not surprising at our data, you can't read the names, but two of our big important tertiary care centers, they have probably the lowest ALC wait times because we've got to churn those beds faster than anywhere else. Some of the acute care sites aren't as active. They may have medicine beds and that's it. And so the ALC wait time is a little bit longer, a little bit more tolerable in those situations.
Not just that, the day zero then is when the patient is medically stable and becomes ALC, and then it's from that point forward.
That's correct.
Yeah. As soon as they receive the assessment that they no longer need acute services and are ready for placement into a residential care facility.
The other thing about this particular chart is that we put on there is also provided the raw number of clients that were placed, just to kind of put it into perspective a little bit. So if we've got a really high number for one hospital, but there was only one or two clients and they happened to wait, and the overall ALC of those patients wouldn't be necessarily as high as if you see a lot of admissions and a big number. So we kind of put it in perspective. The other thing, I'm just going to scroll over here. We can see the trending information on this. If you look on the chart on the right, how are these numbers doing over time? So we've broken it down by month for both acute admissions and admissions for clients coming out of the community. So we can see I've got a 6-month trending chart here, and in real time we can update the time frame that we're reporting on just for the little pick list here in Canada. So I'm going to move on to the declination section here now. And as we talked about a little bit earlier, we've got this overall 31% decline rate. Okay, that's great. But really, what does that actually mean? Well, we've got a chart on the right that actually breaks down according to the declination reason. So you can see that we've got sort of the big three reasons, which are somebody from Helen's team, someone from the access office has intervened and had to respond to different pressures and that sort of thing. So, maybe that's telling Keith one sort of thing. Then we've got the client counting refusals. Again, that's a large portion of that 31%, so maybe that's not as alarming. And then we've got just, so the client doesn't match for various reasons. And then the other ones tend to be a little bit smaller. Lack of physician, for example, doesn't want to transfer anymore, and then we get into the staffing in here. So it's a very small component of the bigger piece of declinations. The other thing we can do on any of these screens is all of these charts here are actually clickable. So here we've got just the raw number of declines for each geographical region within Fraser Health. But if we wanted to get that to the individual facility level, we can just zoom in by clicking on the chart.
This we've got anonymized them.
These are anonymized, so facility, I just numbered them as opposed to showing the actual facility names, but these are now all of the facilities within Burnaby that I clicked on, and you can see how many declinations were there. The rest of the charts on the page also update, so you can see within Burnaby that the overall decline rate happened to be 25%, so it just kind of updates and gives you some more context there.
I'm sorry, Keith, then can you click on, say, facility 38 and tell me the reason for declination?
Absolutely. So let's go. So facility 38 had a lot. So now we're just looking at facility 38. They declined 36%. And again, the pie chart on the right is now just a reflection of declination.
So on that particular one, you can see a huge portion, a large portion looks to be match. Unit doesn't match. So that's a red flag for me. They're declining somebody because they think maybe the acuity level is too high, or maybe whatever reason the facility said, I don't want them. Right, and so that starts to slow down our system because it takes longer for the backfill the vacant bed, it takes longer to match the person somewhere else. So we're not tolerating that as much anymore, so because we brought this new care model, we've equalized the playing field, we have set expectations in terms of hours, we've prescribed in terms of what the multidisciplinary team should look like, based on a clinical approach to that, so the excuses are starting to run a little bit thinner. The only justifiable one, major one, is a lot of our physical plant for our buildings are quite old and can't handle lifts. Even portable lifts are too small. So that could be still a justified reason.
But also your bed configuration. If your neighborhood or unit wasn't configured right, would that be captured here? Or you've already drilled down and done all that?
No.
That's another way to come at it. I think it's from somebody from more of a systems perspective, if we're seeing a lot of decline because it was inappropriate match, that's a cue for us to look at how the matching is set up for that particular facility. Maybe they're set up to accept clients that in reality they can't take. We need to adjust that, so it's a bit of a flag
But
there.
I think that goes into some of the discussion we've had in terms of how you set up a facility in terms of separate floors, separate units.
Yeah.
Because we have our facility set up as a generic facility.
Yeah.
So it may be the roommate, remember I was talking about, 6 people in a room or 4 people in a room, so it may not be appropriate for that room. So that's why we want to refine our declination reasons a little bit more in terms of not suitable for the particular room or the unit, or some of the discussion in terms of setting up sort of sub-facilities within the facility.
That's
So,
right.
The cognitively intact unit versus, you're not going to put someone with dementia in that particular unit. So kind of refining some of that work.
And that's, I think, some of the motivation behind the work that Caitlin's doing out in Vancouver Island, separating it out by unit to try to cut down on the inappropriate matches.
And we've done that in Terry Health, and we still have to drill down more, but we have done that.
How often is this refresh? Is this real time or?
It gets refreshed on a scheduled basis, which is typically nightly. So the data is fairly real time. We certainly have the ability to adjust that as needed.
I think the occupancy rate, I've had it on my screen and I can see the numbers changing, so that might be more live in terms of the occupancy.
It should be, as far as I know, it's a nightly kind of scheduled refresh. So yeah. Any other questions?